Good morning. Thank you for having me here. I think a lot of it has been covered by surgical, medical and surgical gastro again. I probably have zero role in the management of an early gastric cancer. I am a medical oncologist by profession. I think majority of what the slideshow have been told by all the faculty here. So, it is something I rarely see in practice. Probably in the last 18 years of practice, we probably saw about 2 cancers of T1, N0, M0 early gastric cancer. Have rarely seen. What we understand over the last few years of studying or few minutes of being here, diagnosing an early gastric cancer requires a lot of expertise, lot of training, and somebody should be doing the same thing again and again over a period of time. Otherwise, we tend to miss a lot of EGC. 50% of all gastric cancers worldwide, especially East Asian countries, are early gastric. Western countries is about 20%. In India, whatever limited data we have, it's less than 5%. We have one prospective study from Rajiv Gandhi Institute of Cancer, Delhi, where somebody had gone to Japan, trained for 3 months, came back and then only practiced upper GScopy for 2 years, screening and detected about 3% early gastric cancer in 1440 endoscopies. So, I think diagnosing an EGC requires a lot of training, very subspecialized, and in our country we rarely see. Okay. And the management of EGC has been clearly explained. Majority of it is endoscopic submucosal resection, not mucosal resection, submucosal dissection. EMR is less than 1 centimeter, non-ulcerated, very well differentiated, intestinal phenotype, good histology. Otherwise, anybody not able to match the criteria for absolute endoscopic resection criteria should proceed on with surgery. That's okay. I think slides are getting a little difficult, because majority of what I say is repetition of what the dignitaries have already told. So, I think people who don't match absolute resection criteria should proceed with surgery. Even if it's piecemeal, poorly differentiated, ulcerated, no taking chances, because I as an oncologist always believe that the disease is greater than all of us included. We are medical oncologists, so we see a lot of sick patients, we see recurrences, we don't tend to be heroes. Surgical oncologists, surgical gastros, resect, they are heroes. We are usually character actors who take the who make the patient survive a little longer and make the suffering a little less. So, I think the basic takeaway point of this session is EGC is very subspecialized, requires a lot of expertise, requires a lot of training, and certain screening modalities, especially in high risk areas like Northeast, pickle consuming, meat eating states like Andhra, Telangana, where a lot of pickle consuming and meat eating happens, should have certain screening programs included in the practice. Otherwise, that's it. Thank you.